All right, let's dive into this case step by step. Starting with the chest X-ray, I notice reticulation at the left lung base, though overall lung volumes are relatively preserved. The rest of the lungs look clear, and the cardiomediastinal contour is normal. There's also evidence of bony remodeling in the midshaft of the right clavicle, which could indicate prior trauma or another bony process. Now moving on to the HRCT findings. Here, the inter- and intralobular septal thickening really catches my attention, with a clear basal predilection and involvement of the anterolateral periphery in the upper lobes. There's volume loss in the lung bases, which is associated with architectural distortion. I can see the oblique fissures are displaced, and there's traction bronchiolectasis in the lower lung zones. Honeycombing is also evident in the basal regions, which is an important hallmark of fibrosis. Notably, there's no significant ground glass opacification, pleural plaques, effusion, or lung nodules. Other findings include small volume mediastinal lymph nodes, likely reactive to the fibrotic process, and heavy coronary artery calcification, which is incidental but clinically relevant. The esophagus appears normal, with no signs of dilation, and there are no abnormalities in the glenohumeral joints or liver density. Putting these findings together, this case strongly points towards fibrotic interstitial lung disease. The pattern, especially the basal honeycombing and traction bronchiolectasis, is highly consistent with usual interstitial pneumonia or UIP. The small mediastinal lymph nodes are likely reactive and not concerning for malignancy. Now let's consider the differential diagnoses. Basal fibrotic lung diseases can include asbestosis, but there's no evidence of prior asbestos exposure or pleural plaques. Rheumatoid arthritis-associated interstitial lung disease is another possibility, but there's no evidence of arthropathy or other typical lung manifestations. Scleroderma could also be considered, but the absence of esophageal dilation makes this less likely. Iatrogenic causes, such as methotrexate or amiodarone toxicity, are always worth considering, depending on the clinical history. In terms of management, the next step is a referral to a chest physician for further evaluation and to exclude other causes of basal fibrosis. This case should be discussed in an interstitial lung disease multidisciplinary team meeting to determine the best course of action. From a radiological perspective, reviewing any previous chest X-rays or CT scans would be helpful to assess for interval changes and evaluate the progression of the disease. To summarize, this is a classic case of fibrotic interstitial lung disease with imaging findings highly consistent with usual interstitial pneumonia. It highlights the importance of integrating imaging patterns with clinical context to arrive at a diagnosis and guide appropriate management. If you find cases like these helpful, make sure to subscribe to our Radiology Made Easy channel. Turn on notifications so you don't miss any updates, and best of luck in your studies and exams.